afternoon, everyone. Thank you for joining us for the Abiomed J&J MedTech Heart Recovery Luncheon Symposium. As you're getting your lunches and getting settled, we will be starting our program. It's going to start off with 3 speakers. It'll give about an 8 or so minutes talk. After that, we will transition to more of a panel discussion and allow for interactive questions with the audience. So I will hold the questions until the 3 talks are over. I think we can go ahead and get started. Most everyone's in their seats. I'm also having one of the Impella 55s brought up so we can kind of see what that looks like. It's also at our booth over in the exhibit hall. Our first speaker today will be Dr. Lobdell. He is a professor of surgery with Wake Forest Medical School, the program director for the Cardiothoracic Surgery Fellowship at Sanger Heart and Vascular Institute in Charlotte, North Carolina. Yes.
Welcome. I hope you're enjoying it. I certainly have enjoyed walking the streets, looking around, seeing the history. It's quite an amazing place, so thanks for having us. For those that don't know me, which is probably the majority here, just so you know where I'm coming from, a background of both congenital and adult cardiac surgery. I've been in Charlotte for the last 20 years with Sanger Heart and Vascular Institute, and I'll share with you some things that I hope stimulate thought and discussion as opposed to teaching you how to put in an Impella or to take it out, which we'll leave to our colleagues here. Disclaimer standard, I think you're going to see this for all of us. So bottom line up front, I think that these higher risk patients that we're talking about are really things that make us focus on our leadership as surgeons and people that are clinically oriented, like the intensivists, and then the team that we have, particularly in face of a lot of turnover, that sort of thing. So as you think about these problems, it's not just the technical challenge of putting things in, managing them, taking them out, but how do you lead these teams and get them to work at a high level? And some of the work that we've done in our area because of racing has been with Hendrick Motorsports. And one way to think about quality and safety or performance and reliability is in terms of a race car, and that is going fast is kind of what you want to happen, and the safety or reliability is what you don't want to happen. And while those two overlap, you really have to think very deliberately about how you go about doing those things. And we can talk about that if it's something that resonates and you want more. But again, specifically, think about quality, focus on things that are common that you really want to happen. Safety is reliability, and it's things like deferring to expertise and an extreme focus on what you don't want to happen. So as we're here today, we're going to talk about temporary mechanical support and how it's a therapeutic tool. I hope that you would agree when you see the few slides that I have that proactive is better than reactive, and the implications are both short and long term. So I think as I've reflected on this, what I've really learned that there's probably 4 areas that you really have to focus your attention. Risk assessment, monitoring, what are your goals and for how long, and what do you do therapeutically to manage your patients. So specifically on risk assessment, I think it's useful in North America anyways, using the STS database, which captures 96% of patients that are operated on. Think in a systematic way, meaning top to bottom, neuropulmonary, cardiac, about your patients and things that may not be quantified in risk. An example would be with this evolving thought of frailty, and then specifically with respect to the operation, the anatomy, and then the associated physiology. There's a big move towards less invasive monitoring. I think in these patients, we're going to be thinking higher risk, more invasive. Again, shared mental model. The team has to know what you want to happen and for how long, and those are incredibly important in all of our patients, but particularly in these high-risk patients. And with respect to therapeutics and temporary support, goal-directed therapy, unloading the LV, and doing this preemptively or proactively instead of waiting too long. For those that are interested, we wrote kind of an overview of enhancing recovery and temporary mechanical support. I think it was published in February in Current Opinions of Anesthesia. And what we did was emphasize by phase of care the elements and what we think is most useful. But probably more important than any of that is this concept of complexity and who does what when. There's what's known as the Cunnivan framework that a guy named David Snowden created, and it's the way I often think about our problems and categorize them. But if you think about something that's simple or known as clear, nursing and respiratory, they use pathways, and that's supported with, in today's world, things like the electronic health record. If it's complicated, our advanced practitioners, these are where we have protocolized orders. Think of something like AFib, and they employ that. And again, that's often in an electronic health record. But when you get to complexity and chaos, that's where you need a physician, things like checklists to make sure you've considered everything. This is where things like consultations or even EICU or those sorts of tools where we can bring in experts are valuable. And then chaotic is really kind of where that extemporaneous heart team comes into play, getting people together, discussing things. And again, in a EICU is a great example where you can bring people across geographic boundaries to converge and look at problems. So specifically today, we're here to talk about Impella, and the value here is to interrupt the vicious spiral that takes place. And we can take advantage of both goal-directed therapy, the forward flow, unloading the heart at the most vulnerable time, getting them through the perioperative period, but also preserving myocardium. I think we can take a lot of hints from our cardiology colleagues that have access to a greater number, and maybe some studies that we don't on things like AKI that demonstrate the value of this, and similarly the earlier studies that are being done about preservation of long-term myocardial myocardial function. For what it's worth, and the reason I mentioned preemptive being better than reactive or proactive better than reactive, this study that Danny Goldstein, Ed Soltis, and I did was presented, I want to say it's like 18 months ago at STS, but we were looking at STS data. It was around 40,000 patients that were done between 2018 and 19, and looking at post-cardiogenic shock. We had our definition where they went in and they were okay. These people with EF less than or equal to 35, but then required support or died of cardiac cause. And what we found in that subset that had TMCS was, if you look by phase of care, mortality went from 9 if they had a pre-op, 15 intra-op, 43 post-op. Same kind of thing with acute renal failure, which is, I think, a window into the goal-directed therapy value that you get from something like Impella or the microaxial flow device. And while this isn't perfect, what it does show you, again, is preemptive or proactive correlates with better outcomes. There's a lot to be determined exactly why, but it's pretty strong evidence. So in summary, what I really want to stimulate the discussion about is how do we get from A to B as leaders, these teams, what we want to happen, what we don't want to happen, what sort of tools do we have to communicate those, whether it's goal sheets or checklists. Again, that TMCS should be thought of as a therapeutic tool, proactive being better than reactive, and that there's short and long-term implications. So again, think shorter term might be acute kidney injury, longer term would be preserving myocardium and better long-term myocardial function. So thank you.
Thank you so much. That was an excellent talk. Can't wait to discuss it later. I want to introduce Dr. Zishan. He is with Advent Health in Orlando, Florida, and he will be giving our next presentation.
So good afternoon, and thank you, Dr. Kane, and thank you for the opportunity to talk a bit about what we are doing in Orlando. Is this the one that moves back? Green is forward. So I lead the shock ECMO and the heart and lung transplant program in our institution. This is my disclaimer. So I think it's a good segue from Dr. Lobdell's talk about a case, and we have done a few of those with low ejection fraction and temporary MCS. And I'll show you the case and the videos thereof intraoperatively and how we do it at our institution, and of course then we'll be open for questions and discussion. So it's for a 78-year-old male, usual patient, smoker, hypertension, CKD, and he had presented to the ER with chest pain, had and STEMI, and they had shown a disease in all the three vessels. Let's see if it runs. This is the cath. Probably you have seen plenty of these like these ones, and this is a right-sided disease. This was a bit of the left ventricular function that was severely diminished. So we elected to do a temporary MCS, in our case 5-5 supported cabbage, and we did 4 grafts, and we did a central 5-5 implantation to support the left ventricle to be able to be weaned off from the cardiopulmonary bypass. So I'll show you some of the steps of the operations just to kind of show how we have done it at our institution. We do a central impella implant with a 8 millimeter or 10 millimeter graft to the ascending aorta. As you have seen, the clamp is still on, the heart is still arrested, and we have exteriorized this graft suprasternally, and we just kind of creating a bevel here. And then we will bring the impella device through this graft into the ascending aorta. I don't know if I can move this forward a little bit faster. So see here I am looking with this little sucker to deform the aortic valve, so I can place the impella directly through the aortic valve without using a fluoroscopy or TEE guidance. In this particular case, it was difficult for me to see, so we elected to, that we have done a few times, a small aortotomy just above the right coronary artery. Let's see here. Maybe, yes, so we made a small aortotomy, and we opened the aorta like we do a much bigger for the aortic valve replacement, and then we could directly see the aortic valve easily. And then we will, I'll move on to the next slide. I think it will be easier for you to see what we actually did. So now you see we are bringing this impella through the graft from the suprasternal area, coming into the aorta, and then once I have it in the aorta, I can directly visualize the aortic valve and place the impella in the appropriate position across the aortic valve. And then mind it, all this being done in a fairly quick manner while the patient is still on cardiopulmonary bypass with clamp on. Once we are all done and we close the aortotomy, this is where the end product is. We close the aortotomy and then we sew the graft around the impella shaft. And now the heart is beating, and you can see on the left side in the panel that, we have the impella in the place, and this is how it looks like. And this patient was extubated on the same day. It was had physical therapy, walked next day, and then epinephrine was weaned off on day 4. We removed the impella on day 10 after progressive weaning from it, and patient was discharged to home. So this was our, one example of some of the cases we have done in the recent past. We have done about 80 cases like this, including the valve cases and the cabbage and the coronary cases. It really allows us to separate the patient from heart-lung machine in an easier fashion with low inotropes or no inotropes, and then allows for a early post-operative kind of recovery in a faster manner. And when we come to remove it, we usually remove it in the OR with MAC and local anesthetic, or we can also remove it in the ICU. And we just basically open up the suprasternal notch, that 1 centimeter incision under local anesthetic, remove the impella, pull the graft, and staple it shut, and then close that 1 centimeter incision. So that was our case, and from there on, I think I'm pretty much done, and ahead of my time. So thank you so much for your time and attention.
Thank you, Dr. Zidhan. That was excellent. Our last speaker for the speaking portion is Dr. Zias. He is from NYU in New York City, professor of cardiothoracic surgery.
Thank you. So these are my disclaimers. I'm going to go through my slides a little bit faster because I want to show you one slide that's probably the most powerful slide of the whole presentation. This is a patient that you see here, post-op day 1, walking out of his room after coronary bypass graft surgery times 5. His ejection fraction was about 15%. He had moderate emphysema. We did the case. We extubated the patient on the table. As a rule, we try to extubate every patient we operate, even if the patient has circulatory arrest. So all our cases, and about 90% of our patients get extubated post-op day 1 or post-op day 0, meaning in the operating room. So the difference with this patient is this patient 10 years ago, when we didn't have this device, which is like a pencil, would be an outlier. What does that mean? An outlier is, and I'm sure you had multiple of these cases at your institutions, you do a perfect operation, but because of pre-existing conditions, either because the heart wasn't working, meaning the ejection fraction was low, or because the patient had pulmonary hypertension, his lungs were not very well, you would operate on this patient, you do the best operation, the patient would end up in the ICU on 1, 2, sometimes 3 inotropes. Most of you would not dare to extubate him. Probably by day 5, you'd be thinking, okay, we win some of the drips, now we can extubate him. He would still be in the ICU, so basically, post-op day 7, he would have poor nutritional status, and then you would try to transition him to the next level of care, which is rehab, and you would probably have to find a rehabilitation facility to send them. So we had a lot of these patients, and we have really outstanding outcomes at NYU, and we put a lot of emphasis on quality and efficiency. And if I was to try to tell you, well, how do we measure quality and efficiency? It's very, very simple. Quality means that nobody dies, as crazy as that sounds, because some people, yes, will die, but guess what? In a cohort of about 130 patients that we operated putting the Impella, we had no intra-hospital deaths. 2 of our patients that we sent them home died at home. The majority of these patients were not sent to a facility, a long-term care facility or rehab, because the moment you have a patient like this walking around, that means that he'll be able to eat, right? And he'll be able to do the daily functions of living without really delay. So the second part of how do we measure quality is morbidity, which includes any possible morbidity you can find. You can operate on a patient, even like the one that was shown before, and a single episode of AFib can have his care out of control, meaning one single episode of AFib, his heart rate goes up 120, you start giving epinephrine or levo, because again, you have to cardioverter him, et cetera, can essentially mean that he can die from a simple episode of AFib, when you have the Impella, meaning when you have the ability to control cardiac output, nothing really can happen. I had patients of mine who had ventricular fibrillation after this type of surgery. The only thing I did is went to the bedside, increased the flow of the Impella, and shocked them. In a few patients, you do have to do CPR because the Impella automatically, when there's no forward flow, gets confused. But either way, what I'm trying to say is that there's no other way that you can change the outcome of this outlier patients unless you control the heart function. And the only way that I know of to control the heart function is putting the Impella, which in most cases now, when I do an implantation of the Impella, it takes me 10 minutes. I do all my Impella implantations centrally, and since I do the majority of coronary bypass, and I consider myself more of a coronary surgeon than a heart failure surgeon, the last thing that I do, I would finish any operation. The last thing I would do is, as I tell my fellows I will do the last proximal anastomosis. I will put a 10 millimeter graft right at the base of the innominate with a cross clamp. And I don't open the aorta, I don't blindly, with the heart not moving at all, with a cross clamp on place, I will go around the aortic valve and just push the impella out. And then I use the impella to come off bypass, which means I don't use any inotropes. The only times we use inotropes is really to help the right heart, and many times we would use 10 mics per minute of dobutamine to come off bypass. And if the patient has more heart dysfunction, we would use nitric, etc. So most of these patients, when we talk about quality, we mean that we're not going to have any deaths. Everybody going to be is going to be discharged at home. And then how do we measure efficiency, which most surgeons don't really think about, because the only thing we care about is to have outstanding results with no deaths. As long as the patients go home, especially in the United States, 30 days, we're off the hook. But that doesn't necessarily mean that that's efficiency, because you can send a patient to a nursing care facility where he's going to be there or she's going to be there for months at a time and maybe never go home. So then we're not really serving patients the way that we should. When we measure success as a 30-day survival, obviously that's false. So we measure efficiency by enhanced recovery, which means try to extubate at the table. Some people cannot extubate the table, so we extubate them within 6 hours after an operation, and then try to minimize ICU stay. I say that for every week that you stay in the ICU, you need to spend a month in rehab. Now, if you do the math, you're wasting a lot of money trying to do that. And avoiding rehab, that's another thing that comes with the same bundle, because especially in the United States, when the hospital gets paid for a specific operation, it gets paid as a bundle, meaning gives X amount of money, and that money goes for the surgery, goes for rehab, it goes for everything else that you do for the patient, and including home services. And we use that in the US because, again, we try to minimize hospital stay. And if I was to tell you that our elective cases go home post-op day 2, most of you would roll your eyes, but this is our routine. It wasn't easy to do, but it was accomplished by everybody changing their thought process, meaning everybody has habits, and we all tend to fall to our habits, especially when we are under stress. So in all of these cases, we are proactive. We decide before which patient will get an impella. We're not always right, but I would say 80–90% of the times right in figuring out who needs the impella. And then you as a surgeon have to make a decision. Well, you either undershoot or overshoot. If you overshoot, that means you're not going to have any patients who dies under your care, and everybody's going to go home. If you undershoot, it means that a few patients will die because you don't use the impella so often. And of course, the impella is very expensive, but it's much more expensive for any patient to be in the ICU for a week. A hospital stay with 5 days of staying in the ICU pays for the impella. So even in systems, let's say outside of the United States, everything is private practice, even in systems that have national health care, it makes sense to be proactive and not reactive. So in this cohort of patients, we decide preoperatively, we say, okay, we're going to use the impella. Everybody's sensitized, from the nurses to the anesthesiologist, and everybody knows what to do, and there is no delay. So we can finish an operation, do the index operation, take 10 minutes to put the impella and go to the ICU, extubate it. That makes a huge difference. So having said that, and we start using the impella not because we love the concept of a new toy. We use the impella because it filled a need, the need to not have outliers anymore, not to have, meaning 10% of our patients And we consider outliers, and back then my chairman had called me in his office and said, we have to figure something out because 10% of our patients stay in the hospital for weeks at a time. And most of these cases, even if they survive 6 months down the line, all these patients are dead. So using a temporary mechanical assist support, such as the Impella, which is, and I show it to all my patients I have in my office, and I always ask the patient, I say, well, we can do the surgery the conventional way. You're going to be in the ICU with a tube down your throat. Chances are you're going to need feeding through your nose, et cetera. Or we can put the Impella and you'll be walking, as you saw in the video, we would have you walk around and you'll be going home probably in a week or 2 weeks, depending on how long the Impella will stay. And I had patients that I kept the Impella 3 days, and I had patients that I kept the Impella 6 weeks, right? A lot of things happened, but at the end of the day, we always had alive patients who went home. So having said that, at NYU, we start building this high-risk program, and we do have now a high-risk program where we talk about all the patients. Before every patient gets operated, all the surgeons get together, and we are 20 of them, so just figure out how easy that is. And we talk about the patient. We decide what's the route that you're going to take, and if a surgeon says, well, I can do the case, I can come off bypass, most of us will, at least the ones that are doing this for 30 years, will say, everybody comes off bypass, give them rocket fuel and they will come off bypass. That's not the issue. The issue is what happens day 2 and day 3 when they start having AFib, et cetera, et cetera. So in developing this high-risk program, essentially what we did is we have protocols for everything. For example, how do we take care of AFib and what's our AFib rate? Our AFib rate is not 40%. It's less than 5%. And you'll say that's impossible. And I will say it is possible because most of our patients go home post-op day 2 or 3. AFib, usually, of course, post-op day 3. We don't even know if they have AFib, nor do we care. Why? Because everybody gets the left appendage clipped, and everybody gets to decrease the rate of AFib. Everybody's on beta blockers, calcium channel blockers, because we use more than 2 arterial grafts in all cases, especially radial arteries. Everybody gets, for 3 days, intravenous steroids. And everybody gets PO amiodarone. 400 TID the first day, and then we continue that up until 14 days. And we follow patients very intensely, meaning if a patient goes home on Tuesday, Wednesday, they come back to the office so we can review the medicine, and then they can call our office every day. So I don't want to belabor the point, but the message that I have is in this cohort of patients to be proactive and not reactive. If you're reactive, 50% of these patients don't survive either way. And we made this high-risk surgery pretty much routine that all 20 surgeons now have bought in the idea and have changed the habits of saying, well, I can come with bypass. I think he's going to be okay. We never think he's going to be okay. We're always certain that the patient is going to survive. Now, in terms of the last message that I want to tell you is it took us some time out of this. Now we're probably over 150, 170 cases that we have done with the Impella. This is the example of a patient. Oops. I don't know how this is going to play. If we can make it play, this is basically the way that we explain the Impella at the bedside. In this particular case, you can see that the patient has a
You're going to feel a little pinch and a little bit of burning.
Okay, we can decrease that, I guess. So essentially, we use lidocaine to numb the incision, open the incision, grab the graft, as you will see, and this will play, and essentially decrease the Impella to P1 or P2 and explant the Impella at the bedside. And this is our routine because, in my opinion, it doesn't make sense if you have a patient that is high risk and you operate him and he's doing great, and by this time he's beta blocked, to bring him back to the OR and do this in the operating room. That obviously wastes a lot of, it's very expensive to come back to the operating room where in all cases, especially The last 50 cases, we do the explantation under local anesthesia at the bedside as we talk to the patient. And in most cases, my fellows do this part. I'm just around if they need help. So this is exactly in the way we do it. In most of these cases, we use the white plug that you see there to essentially secure the impella, because sometimes movement in the impella can happen. So we secure the impella both at the skin and with that white plug that you see there. And as soon as you take the white plug, we just pull the impella out. And 100% of the cases, some clot comes along that is housed around the 10 millimeter graft. And the reason that we have not seen any patients that had any strokes from removing the central impella is exactly that. Most of the clot is inside the graft and it comes out. Or if you put the impella through an axillary incision, then you can have embolization because you have a double amount of impella that the aorta sees. In most cases, when you put an impella, centrally, you have this much of, wire that you see exposed. So the chance of having a clot there is always minimal or non-existent. And then you just pull the impella, and if you don't like somebody, you ask them to sit behind you. There's always a huge amount of sort of like blood coming, as you see there. And there you go. So I think that's the end of my talk, and be happy to answer any questions.
Thank you, Dr. Diaz. Thank you. I want to open it up to the audience to ask any questions that you may have. Please come up to the mic so everyone can hear you. And the panel is also going to have discussion at the table while waiting for your questions. So you guys can open up for conversation.
Well, as an aside, I want to ask the audience if any of you have any experience or if you ever thought of using a temporary mechanical support to get sort of like to deal with this outlier patients that I'm talking about.
I have a question about the timing of forming the graft on the ascending aorta. Both of you guys did it on cross clamp, and I've done several of these, and mostly I've done it with a partial occluding clamp at the outset of the operation with the heart beating. How do you de-air the graft when you put the graft with the cross clamp on? How do you de-air the graft? How do you, I know how you position it, but have you seen a case of the impella perforating the LV when the heart is arrested? And that also adds about, I guess, 10-15 minutes to cross clamp. And I wonder why you would do this on cross clamp as opposed to being off.
Well, I can tell you from my experience, it is a lot faster having done this any possible way you can think of. Initially, I used to do it, I would come off bypass and then try to put the impella, and I would go try to put the impella next to the aortic valve. And under echo guidance, I never used wires in the past, push the impella down. So, and many times it would take me 10, 15 minutes, 20 minutes try to, push the impella down. So as I start doing this more and more after, 100 times that I did that, I said, okay, there's got to be an easier way to do that. And use the impella to come off bypass, because if you're doing it the way you mentioned, which I have done initially in my experience, yes, you save cross-clamp time, but you don't save bypass time because maybe you come off bypass, but you do have, in many cases, have to use high dose of inotropes to stay off bypass. So I do it this way simply because it's a lot faster. I de-air the same way that I de-air any case, meaning before I take the clamp, I feel the heart, and I use my hand to essentially de-air the heart from air. Most of it comes through the 10 millimeter graft, either way. And in some cases that you have still a small amount of air, the impeller sort of like, gets it out. Now you say, is that a problem? I have not seen that, this is a problem. And it's, in my opinion, a lot faster and maybe easier to come off bypass because you use the impeller as a cardiopulmonary bypass machine to come off bypass. Have I seen perforation? No. I had one perforation when I asked a colleague of mine to put the impeller through the axillary approach, where he got it down the ventricle, he couldn't position it the right way, and there was a perforation, and luckily enough, obviously it was very difficult as I was able to fix it and position the impeller in a different way. But we did not have any perforation.
Yes, so no, I think, so I'll speak to that if you don't mind. So we had one perforation, and that required 2 pleated proline stitches. That was essentially, I wanted to see the graft before I took the clamp off and I lift up the heart. And long behold, it was a small heart, and it was a female, and perforated through, as we talked about the fragility earlier today, the female patient. So yes, and we were able to successfully repair it with 2 pleated 4O proline sutures on the SH1 needle. So having said that, I think that our evolution has been similar, as Dr. Zayas described, from removing the clamp, side-biting clamp, beating heart, anastomosis of the graft, and subsequent traversing it with the wire in the beginning, without the wire, with deformation, posterior deformation with the 2 fingers behind. And then from there to this iteration where we started doing that, sewing the graft only and then bringing the impeller in and on the clamp, placing the impeller without the clamp with a beating heart, to now our current iteration where we sew on the graft with the clamp on and cross the aortic valve with or without doing the aortotomy. Aortotomy is a lower number, but most of the times you can just go through and it's just fine. And I think it has made the operation far more convenient, far more faster. Also has taken away the dependency on the fluoroscopy or the echocardiographic guidance at any given time, because we already know where we have the impeller placed. So that's one part. Subsequently, I think I had similar concerns like you do, that how are we going to de-air this whole thing? So I think first of all, we use in all cases CO2 in the field, though it's not a valve case, but we do. Number 2, I think that we like standard fashion, like any other operation, before taking the clamp off, start the ventilation, Valsalva, and ventilate the lungs, massage the heart as Dr. Zayas described. I have a root vent on, I turn the root vent on, and I also start the impeller at P2. So it basically fills in the entire system. And then the actual graft itself, most of the time it fills with the blood, and most of the air comes out to the pores, that we can make a needle hole or not if needed. Very uncommon, and usually we can de-air in that fashion. In the beginning, we were having the introducer sheath with the side hole, and we would just use a syringe to just de-air, pull some blood out. It will be completely de-aired, and then we do the subsequent final blue port at the skin level to tie off. So these were the few techniques we used to de-air. And I think I already answered the perforation question.
Thank you for all your excellent talks. I had a question about the anticoagulation protocol, and does that cause a problem in the early postoperative period for your patients?
So very good question. I have seen that partial to be a problem. Initially, in my experience, I used to anticoagulate everybody, where now I don't use any systemic anticoagulation or any heparin on the purge. So on most of these cases, unless they also have a central ECMO, I will use sodium bicarb through, for the purge solution in the impeller. And I never had, an issue 2-3 weeks or so. One of the times we had an impeller that stopped working on a patient who had it maybe 4 or 5 weeks, so we did not use heparin. And we had to explain that obviously by that time, the patient didn't really need the Impella either way. But I have seen, I can tell you from my personal experience early on, a lot of pericardial effusions, even tamponade, when we used systemic heparin. And fortunately, even if you have the Impella, tamponade, the physiology is not the same as tamponade without the Impella, because you never see the low cardiac output and no urine doesn't really exist, because you can always deliver about 2.5 liters of flow. So the kidneys and liver don't get a hit, but you get an incredible amount of alarms, and you give more volume and you get more alarms that you can't feel the heart essentially. So we have stopped using heparin systemically, and we will use heparin on the purge only if there are other issues. In most cases, we will not use it, even though I think it might be against the recommendations.
So, like everything else, I think there's a fine balance. So we were, like Dr. Zayas had moved on to that, the comfort level of having bicarb in the purge and things going just fine. And then we had a clot. We had a patient with previous CABG about 2 months before, and then he had a 9-centimeter inferior wall pseudoaneurysm that we went and we did a double patch repair with Impella support. And subsequently, we did not anticoagulate, as we thought the patient will bleed and might bleed, etc. So then patient developed about 2-centimeter clot in the shaft, and then we ended up anticoagulating for about 4 weeks with incomplete resolution. Subsequently, suction of that clot via transseptal approach with a suction device with a like TAVR, the protection device in the both carotids. So yes, so we have seen that. So current practice is we come out of the OR for first 6 hours with a bicarb, but then subsequently we switch to heparin. In addition, day one, we usually switch to a PTT of 50 to 70. We don't have the ability to do ACT that is recommended at 200 seconds of ACT, but for device maintenance, we maintain a PTT of 50 to 70 from day one onwards. And I think that we have yet to see tamponade in this setting, but I think it will present the same way as Dr. Zayas described. And I think we all surgeons are very meticulous and we pay attention to the hemostasis. But one consideration I always have, that if we have an Impella in the aorta with the aortotomy for AVR or for CABG with the proximal grafts, and the graft itself, the aortic Dacron graft to the aortic anastomosis, there will be 5 liters of flow, 4.5 liters of flow across in the aorta that is unusual at that time, and the dispersion is different. So we are particularly careful about hemostasis, and that will be the message for everyone in the audience who wants to do it, to be just really meticulous with the anastomosis and make sure that there's not too much bleeding.
Thank you. Thank you very much.
Dr. Lobdell, what's your experience?
I was curious, based on that discussion, if we could take a poll of the audience from nothing to routine and sort of see what people are doing.
Yeah, so
Raise of hands.
So yeah, raise of hands for who is doing systemic heparin still with their implants. Raise a hand of who has moved just to bicarb, no heparin. And who is in the middle ground like Dr. Zishan, where he waits till the first 6 hours after surgery to start a low-dose heparin. Okay. So the majority of the people in the audience is still using the systemic heparin here. All right.
And I think it's probably fine in almost all the cases except your concern. So.
Okay. I have a question. For when you're doing your coronary artery surgeries and using the Impella, do you typically put the Impella in the ventricle throughout the surgery? Do you park it in the aorta? Like, how do you approach doing it, or do you wait till the end of the operation?
So you're speaking about patients who already had a 5.5 implanted and they came...
Or you're implanting it in the operating room?
If we
either
are
one.
implanting in the operating room, I think our practice is for cabbage is to do the impella after the cabbage is completed. I think I have done both ways, where I have placed the 5.5 and then have done the 2 or 3 proximals, or majority of the cases we have completed the entire surgery and then have placed the impella.
Yeah, this is our experience too. But we have used the impella in off-pump surgery as well, meaning place the impella through an axillary approach before the surgery, let the patient cool down, especially if you get an MI, and then do an off-pump. And in most cases, especially if we have to lift the heart, go to the circ or FAR PDA, we are usually moving the impella at least 2 centimeters from the ventricle, not to have the possibility of perforation. We never had any problems, but you just have to be cognizant if you use it doing off-pump, that if you leave the impella its original position, when you lift the heart, that you can have a problem. But very honestly, in the majority of the patients that at least we use the impella, the ventricles are huge. A lot of the patients also have MR, moderate, severe, et cetera. So it's usually not a problem. Where you use the impella in, patients with smaller hearts, especially in some pediatric patients, and our pediatric surgeons use the impella in pediatric patients, then you have to be a little bit more careful. In terms of, positioning the impella, as I mentioned before, we had one instance where we cannot position the impella the correct way. If you don't have 7 centimeters from the aortic valve, meaning if you have a short ascending aorta, then it might be better to go to the innominate and put your graft in the innominate. We have done that several times. Or go to the axillary approach. And as I mentioned before, if you put the impella in the axillary artery, you do have to use heparin, systemic heparin. This is what we do. And even with that, sometimes you can have emboli. And the few cases, actually, we wrote some of these cases up. Initially, when we start using the impella through the axillary approach, during explantation, we would use the protection devices that you mentioned. And in most cases, you would see a good amount of clot caught during explantation. So during axillary implant, I think you don't have a choice but to use systemic heparin. But when you put it directly in the aorta, our experience has been really outstanding without trying to avoid heparin for the issues that were mentioned before.
Yeah, thank you. Great talks. This is overall management of someone who comes to the OR with a 3.5 RCP in place, and you're doing coronary bypass surgery.
So the question is, if a patient has already the 3.5, the CP impella, we always upgrade these patients. We never leave the CP in place because we feel that, except the fact that it will definitely move from its position, in a lot of patients, we have a lot of peripheral vascular problems. So in the few cases that we operate on patients with the impella CP in place, we would pull the impella CP in the descending thoracic aorta, do the surgery, upgrade to 5.5 centrally, and then after we give the protomy, we'll pull out the CP.
Yeah, I think we have exactly the same experience where so if a patient presents with a CP in place, we'll go on cardiopulmonary bypass and then pull the CP back into the descending aorta. Furthermore, actually, we exchange it out with a 12 or 14 French sheath in the groin, so it's completely out of the body. And after the completion of the operation, we'll place a new 5.5, either axillary or central, likely central. And then in the ICU, our team can remove the sheaths with a femstop after the protomy is administered and the operation is over and things like that. And it's fairly simple and easy to do. In the past, we used to do a small cut down and repair the blood vessel, but we don't do that anymore. So that's that in our experience. And so, I think I was thinking about this, and I was probably going to ask Dr. Lobdell and Dr. Zayas a question, and probably was helpful for all of us to kind of understand, how do we make a decision to use Impella 5.5 with cabbage or valve operations, or cabbage operation in this particular case? In terms of us, and we have the same mindset that if you think you need it, then you use it. And we may overshoot in 10 to 15% of the patients, but that is far more comfortable, easier, and for patient and recovery than not placing it. But I think that I wanted to kind of learn
Sure.
from both of you as well. Like, how do you decide what EF, what LV and diastolic diameter, what other characteristics?
Well, I'll start more generically. Maybe you can address some of those issues. And I say that because you described getting 20 cardiac surgeons together to discuss this, so I'll speak a little bit more broadly. We've been at this for a while, heart team plus or minus 5 years, and we systematically score every adult cardiac surgery patient that we operate on, and if it's supported with the STS, it's that. If it's not, we try to use Euroscore, so at least we have something that's better than the foot of the bed test. And we set standards for what mortality and what combined mortality and morbidity score makes somebody heart team. If it's lower than that, the surgeons can proceed. As you'd imagine, particularly in this case, most of those patients are discussed. But the reason I mention that is there's a systematic scoring. There are cardiologists and cardiac surgeons, and then I'm sure we're all involved with, now we've got people with advanced heart failure skills, both on the cardiology side and the cardiac surgery side. We've differentiated into people that are doing predominantly coronaries or people in structural heart. So you get down to, okay, not just the numbers, but the expertise associated with it. And then once we've decided this is somebody that's, high risk, low EF, whether it's isolated coronary or maybe mitral valve, is it the right surgeon, the right discussion that goes on? And that's where I say maybe you can lend some more of the technical detail.
Yeah, we have a similar way of figuring out what patients would need the Impella. And as I said before, we are very proactive. We decide before the operation that we are going to use the Impella. We have some general guidelines, and yes, we do use the Euroscore and STO-score, which in my opinion sometimes do not really represent the risk of the patient well. So as general guidelines, we discuss every patient that has ejection fraction of 30 or less. But I can tell you that we've used the Impellas in patients who have an ejection fraction of 40% with moderate mitral regurgitation and renal issues in terms of GFR of 20 or so. I can also tell you that we've used the Impella in a few patients that are on the renal transplant with creatinine of 6, that we don't want them to go on dialysis, that do not necessarily are at risk of dying or having prolonged times in the ICU. We do use the Impella if we have terrible targets. So if we're going to operate on somebody who has terrible targets, we will decide to unload the patient and do as many grafts as possible. We also use it now, as I mentioned before, we use on pretty much every patient gets 1 or 2 radial grafts. We do a lot of total arterial revascularization in our practice. And we have done this over certain years, and we have convinced pretty much every surgeon to participate by offering incentives, not financial incentives, but incentives of making it easy to have the support in the operating room, meaning having, for example, 2 physician assistants harvesting and not have to delay the operation. So as a rule, if we have poor targets, sometimes poor conduits, reduced ejection fraction, moderate MR, huge heart. If the patient is morbidly obese, I just operate on somebody who's 350 pounds with an ejection fraction of 30%. And his targets were good, but again, when I feel that that the patient might get in trouble postoperatively, I'll use the impeller, because in my head, I say it's better to be alive with the impeller than dead, saying that I can do it, without support. So I'm one of these people that I don't use it every time that we decide on the high-risk conference we'll do it, meaning sometimes I'll go to the OR and my pre-op thinking changes, either because I'm very satisfied with the targets, I've done a very good job, and I know things will go well. Sometimes, not often, we will use cardiac MRIs, we'll use viability studies. But as a rule, if we have young patients, and lately we are actually getting referrals from our transplant team, young patients with poor ejection fractions that need coronary bypass. And we'll have the transplant surgeon call us and say, well, can you give this patient 5 years, 10 years off the transplant list, do the surgery, put in impeller, see if we can get him a little bit better. Chances are he will end up back on the transplant list, but even if you give him 5 years or 10 years without a transplant, I think it's a success, because even if you transplant these people, there's usually an expiration date post-transplant.
No, thank you for answering both of you my questions. So just we have similar experience, but I think you are a bit more advanced in the way we are doing it. I think EF is 20% is fairly easy question, easy answer to do. It comes down to you have a 30% ejection fraction. The LV wall thickness is good. The LV and diastolic diameter is not bad. And we go there and it looks about the same in the OR with the TE. Of course, we probably not, even we thought about it, may not use the impeller. But on the other hand, if your LV and diastolic diameter is 6 centimeters, your LV has thinned out a bit, your EF was read to be 30%, and you came and do a TE, it looks like a 15% ejection fraction. That's not uncommon in our practice to have. Then, of course, you're going and you know that you're going to be doing it, so you just go ahead and do it. But I think we have a multidisciplinary team. A lot of times we receive patients from our heart transplant team, as you described, who are non-candidates, either due to compliance, family, or any other reasons or comorbidities, and then they come down to this high-risk cabbage operation and things like that.
We have time for one more question. Yeah.
Actually, it's a comment. Thank you very much for a wonderful presentation. My name is Sharaf Shahada. I am from Essen, Germany, and we are approaching 90 cases with cardiac surgery supported with Embella and different categories. I would like to comment on your last comment, Dr. Elias, which is it's a mindset thing. I mean, when I started with Embella 5 years ago, my idea was a bailout strategy. When the patient needed, I will put an MCS in. And now it's completely different. So I will do a presentation on Sunday. You are all invited to see it about our initial results of our cardiac cabbage surgery alone, but we do a cardiac surgery, which is presented in Toronto as well. The thing is, if you have the time for the patient, it's very, very effective to do an MRI. I mean, there is a huge difference between acute coronary syndrome and chronic coronary syndrome. And if you have a chronic case and you have a time, if you do an MRI, you will understand more and have more idea about how's the myocardium, is it viable or not, is it the target vessels is gonna be effective for this patient or not. So I changed my mindset, I changed our strategy from being a bailout strategy to protected cabbage surgery or even cardiac surgery. Now we did the 90 cases, as I told you. So the thing is, we have to plan it better from the start, and it's not about the patient starts well with 30%. You put him in a heart lung machine, you do a cross clamp sometimes or most of the times. So the myocardium sitting in this time, you have what kind of cardioplegia, etc., etc. So you do some physiological changes at the moment for this case during the procedure. So you don't wait until the last minute, and then you see in the ICU that the lactate is increasing, the enzymes are going up, and you need more norepinephrine. You just put it from the start, and you just go from reactive to protective from the start. And this is, I think, more ideal, and we have a wonderful results with that, and I will show you how we changed it completely from being a reactive to a protective with a very good results. And then we put the patients, after all, in a heart failure board. So he has an outpatient clinic in the heart failure board afterwards, so we don't lose these patients. As you already said, if he has AFib or something in home, he will be decompensated immediately. So he needs time, he needs therapy. So it's not about this time, it's about all the way with these patients, and the age of this patient is dramatically decreasing. There are the patients who are suddenly dying outside the hospital, and now they are coming to us. So it's not about this procedure itself, but it's about a long-term therapy, not only a short. Thank you very much.
No, well said. Thank you. We have the same sentiment. Thank you for your comment.
Lauren, if it's okay, I'd like to ask kind of a related question, because we
Yeah.
talked about quality and efficiency, and we've talked about pre-op and intra-op, but we haven't really talked about what we're doing when we're getting the people ready to go home, kind of medications. But do you have a different pathway that you're using for these higher risk patients than your ordinary coronaries and valves? In other words, do you see them more often, or do you have a different pathway that you send them on?
So we do have the same pathway, but the pathway is pretty intense in follow-up, in the sense that, as I mentioned, the first time we see these patients is one day after they leave the hospital, and then we see them in the office once a week for about a month. Why? Because as they come, except the fact that we can discuss goals with the patient, we also have to decrease some of the medicine that we give them. As an example, I mentioned that we give everybody PO amiodarone. Well, we usually stop that 14 days after surgery. We give everybody steroids, high dose of steroids, to decrease the AFib and actually make them feel superhuman so they can go home day 2 or 3. We stop that usually 7 days after surgery. And so it's a good way, and in most of the coronary patients, we actually check, we give everybody dual antiplatelet therapy. Guess what? 30% of our patients who come to the office week 2, when we check a P2Y12, we see that 30% do not respond. So then we have to change the therapy from aspirin Plavix to aspirin Brilinta, et cetera, et cetera. So we tend to use a lot of Brilinta on younger patients, and older patients we do not. Obviously, the incidence of bleeding is higher when you use these stronger antiplatelet therapies. So follow-up is the same, and it's pretty intense for everybody. And what you've seen is, except the fact that we see the patients feel happier because they feel taken care of, we also have reduced readmission rates. Meaning, if you know people that get any type of cardiac surgery, especially coronary surgery, usually get readmitted either because of AFib or fluid overload. If you see these patients, now I mentioned that AFib is not an issue, meaning you can have AFib, but as long as you control the heart rate, we don't even bother to convert them. We see them in the office next week, and most of them usually go back to sinus rhythm. The few that don't go back to sinus rhythm, eventually we do an outpatient cardioversion. But follow-up is super important because, again, except the fact that you have to readjust medicine and really tailor the therapy to the specific patient, it's also good because, you avoid readmissions, et cetera, et cetera.
Okay. Thank you so much for attending. Oh, yes, we have one comment.
I'm sorry. First of all, I want to say great presentation, and I have an honor of working with Dr. Zias at NYU, so I have witnessed the extubation on the table, the discharge 2 days. One question I had, Dr. Zias, which I don't see the post-op part of it because I'm in the operating room with you, the steroids, a patient coming back because their hemoglobin A1C pre-op, majority of these patients are actually at the vicinity, either from Asia, that part of the world. So hemoglobin A1C is 9 or 13. These steroids, do you see any post-op wound infection?
So we don't have an increase of post-op wound infections, but in these patients, we do have issues controlling their sugar with steroids. Usually, if you give steroids the way we do, intravenous steroids, 60 milligrams the first day, meaning day 0, 40, 20 for 3 days while they're in the hospital, you can control the sugars in the hospital with insulin. The problem is, do you send them with a steroid pack, Medrol pack, at home? In these patients who are, as you mentioned, that have A1Cs that are, quite high, we shy away from giving steroids at home, even though we follow them so, very closely, et cetera, because it's very easy for, their glucose management to go haywire and cause issues.
Thank you. And when do you repeat your echocardiogram to decide if these patients need a device versus like a life vest discharge home?
So every time we do an impella on a patient, our routine is we explant the impella. The next day, we will do an echocardiogram. If the ejection fraction is less than 25%, at least in the U.S., for medical legal reasons, we will prescribe a life vest. So all these patients do get an echo before discharge, and many of them at 3 months after surgery to decide if they need a device, such as an AICD or sometimes even resynchronization therapy. But we wait three months.
Thank you.
Thank you very much. Thank you, everyone, for your attention, your questions. You can stop by the booth and get some more hands-on look at the Impella if you have questions for us there. Have a wonderful rest of the meeting.